Good afternoon. Kent Comfort here again with Tallgrass Economics. Today, once again, we're going to have Dr. David Kingsley on as our guest. And today he's going to, in the series that we've been doing together, he's going to tell us a story, a real live story about a specific example in the nursing home industry that you should know about, and chances are you have not heard about because the media hasn't done a great job of putting this critical information out there for the general public. So without any further explanation, I'm going to now welcome Dr. David Kingsley to join us once again. Dave, good afternoon. Good to see you again.
Good afternoon, Kent.
So I've told our audience that you have an interesting story to share today that really illustrates some of the issues that define ways that the senior care industry in this country have gone off the rails, I guess is the best way to say it. So I'm going to just be quiet here and go ahead and let you start sharing this story.
Well, you know, Kent, our theme is explaining why the healthcare system that funded by the U.S. government is not really capitalism. That the myth that the capitalist system can deliver healthcare better than private industry is a myth. And what we're trying to do is explain to our audience the basic elements of capitalism. What does that mean? And really, it's not that complicated. The free market, what we consider a free market, the ability to bargain over prices and so forth. And I was looking at a history of the Trump administration during COVID. It just recently came out. There's several histories. A couple of credible journalists from the Washington Post wrote the most recent history, and we're going to see these popping out now at a fairly rapid pace. And they're not really good histories, but there are some interesting facts that are credible in these stories. And the one story that I thought was very interesting and relevant to what we're talking about is the salary that is received by the people at the highest levels of government who are responsible for the health of all Americans. This one story is that's very interesting is Robert Redfield, who was appointed as the head of CDC, was initially given a salary of about $375,000, which is really way out of sight compared to previous CDC directors. His boss, Alex Azar, who's over HHS, all of American health that's funded by the government. We're talking Medicare, Medicaid, and on and on and on. Preventative health, acute care, anything the government has to do with our health, Azar is responsible in HHS. He was paid less than the CDC director. He had a little less than $200,000 salary. When Azar was somewhat insecure because he was always on Trump's bad side, and he was worried about getting fired about any day of the week.
Right.
And when he found out that Redfield was making $350,000, I think it was $375,000, he called him in and said, "You're not going to make that much. We're cutting your pay down to $209,000." He was still making more than Azar, but Azar was able to pull some rank on him and I guess satisfy some of his ego needs. And I want to mention that because I want to talk about one corporation. I won't mention the name of that corporation at this point, but we'll be talking about it down the road. It's one of the biggest nursing home chains. A couple hundred, I think they have 220 homes. And this CEO has a base salary of $4 million, with his base salary and his stock awards and his incentive bonus, he was making $4,500,000. Now, you know, he's got 220 nursing facilities. He's making as much 20 times what these high-level government officials are making that are subsidizing his business, basically. He failed miserably in terms of delivering healthcare during COVID. They had 1,695 deaths in just 200 of their facilities between May of 2020 and April of 2019. You know, when you put that in some perspective, in Hong Kong, there were 760 facilities total. They had 30 deaths. So you're comparing 220 facilities with 1,695 to 760 facilities in Hong Kong with 30 deaths. So a preventable disease that swept through the facilities because management was not doing what it needed to do. And we're not talking about that, and as we don't go down the road, I hope we spend more time talking about that. So, you know, I tell this story because it illustrates a myth that we are trying to get across, Kent, that private for-profit capitalism can do a better job of delivering healthcare than the US government can do, government-funded healthcare particularly. And as we said in our last podcast, I'm an old school capitalist. I'm not a socialist. I'm not a communist. I think capitalism is a system I would ascribe to. So we're looking at something called capitalism that really isn't capitalism. And we're using the myth that it is to cover what is really going on. So I want to talk a little bit about what we talked about last time, reiterate a little bit that capitalism is a rather simple concept. The idea is that you have something to sell, I have something to buy, or I have a need to buy what you have to sell. So we negotiate with one another. That's what the free market's all about. That's not hard to understand. And presumably we will reach some kind of a quid pro quo. I will get what I feel I needed and you will get the price that we pay. If that doesn't happen, then we haven't really had a equal bargaining session. Or I may say, well, you're not willing to engage in a quid pro quo. You're not giving me what I think I should get for the price. So I'm going somewhere else. That's capitalism. That's simple.
Right.
Now, to call what we do in government-funded healthcare capitalism is a myth. It's a misnomer. Patients can't negotiate with a provider. They could. I mean, there's a little negotiating goes on. I could go to St. Luke's or North Kansas City Hospital. That could happen. However, if I go to the emergency room and the company running the emergency room isn't part of the network, then I might pay $30,000 for an hour at the emergency room.
Right.
I have no real say about that. I didn't know it before I went. I may have to fight my way out of that. I might not get out of a big bill at the emergency room where an hour's time wasn't worth $30,000.
Well, even more insidious, Dave, you won't know about that 30,000 until sometime after you've gotten home. You won't know anything about it at all. They won't tell you, will they? And tell me if this makes sense to you. Where you can draw the line, I think, and exactly the point you're making is in cases in our life where capitalism works well, it's discretionary. You offer me an opportunity or a product or a service, and you give me a rate, and I can say, that sounds good, let's do it, or I'm not okay with that, I think I'll just pass. I don't have to do it. I either want to do it or I don't, and the value proposition has to be good for me in order to feel good about that exchange. Now the other side of the line is it's not discretionary. I have chest pains. My wife calls the ambulance. The ambulance shows up, loads me up, and before they back out of the driveway, do I say, hey, no, wait, where are we going? Let's call 3 places and get bids before you decide where you're going to take me because I don't want to spend more than X. Clearly, that's not going to happen. I can lay there in the driveway and die if I want to, but that's not going to happen. And that's where it breaks down, isn't it? Where the idea that it's capitalistic breaks down. The matter of, do I have a choice or do I not have a choice? And when I don't have a choice, there isn't any incentive to match the value of what I get to what I have to pay for it.
Exactly. If you happen to be in one of those nursing homes that were one of the 220 in this chain that had a horrible record during COVID, it's very difficult for you as a person who may be so less abled that you need to be turned in bed. You need to be helped to eat. Well, you don't have much bargaining power in that situation.
That's right. That's right.
Even if your family's paying the freight, and typically the family's paying will eventually, if it's a long-term care situation, spend all their assets. And then Medicaid will kick in, people will apply for Medicaid. But you really aren't bargaining with that institution about the quality of care you're receiving and decide to go somewhere else. That just can't happen. So you're pretty well stuck. Right. They're pretty well in the driver's seat there.
Dave, quick question on that. Do you know, and maybe this is something we need to cover in a future session, but do you know the origin of the spend down policy, how that happened, who decided that, who was on board with that?
Oh, absolutely. We know exactly where and when it started, and it will take a session to really get into that. It was 1950 when we amended the Social Security Act, and we said, the federal government said, yes, you can reimburse providers for care, but that went through the states, and there was a means test, which meant you had to be poor to receive that care. Either you paid for it yourself, but if it was government care, you had to show you were poor. That's where the spend down started.
All right.
We can talk about that. We do need to talk about how that over time became reinforced. You know, we talk about complex systems, and we talk about initial conditions, dependency on initial conditions. Those become more and more and more reinforced through time. So that's very much a part of this whole system. But the scary thing about what you and I are talking about, where we have, let's say, government officials who are responsible for the entire nation's health are making a tenth of what a corporate executive is, who's running a very poorly managed system. And we're still perpetuating the myth that the guy making 10 times as much as the government official, whether the government official's failing or not, is somehow more qualified, somehow more effective, more efficient, more competent than that $200,000 government official. There is no substance to that myth. Well, what's scary about this is that the citizenry of the United States has been completely pacified to accept this.
Right.
The rules of the game and the discussion about this have been set by the industry. They have framed the issues. They have a narrative. They have a political strategy. So if you happen to be a citizen, you don't know a whole lot about the financial aspects of a corporation. You don't know a whole lot about how the capital is flowing into and out of these systems, whether it's capital coming from lenders or the capital coming from the tax codes, or it's capital coming from Medicare and Medicaid or your own private pay. So you have various types of capital flowing in, and those go through a very complicated legal financial structure. And we will be talking about how those flow out and enhance the wealth. As we say, the primary purpose of a corporation, according to the ethos that we're now operating under, is to protect and enhance shareholder value. But that is not being highly questioned because, as I say, the rules of the game have been set up. So there will be congressional hearings. There are advocacy groups. There are professional groups. There are activist groups who engage in government discourse, whether it's at a Senate hearing or a congressional hearing of some sort, or whether it's through public speaking, through the media. And by the way, we need to include the media in that. We're really not going to speak truth to power. We're really not going to say, if you are a professional and you are in an organization where your job may depend on not upsetting the powers that be, because the people who are running the system, who are paying the money to the congressional or to the legislators, can cut your feet out from under you pretty quick. So I think it's the pacification of the company or of the country, the professional groups, the advocacy groups, the activist groups that know what the rules of the game are. You can't go to Congress and really tell the truth, because if you do, you will not be asked to come back. You will be persona non gratis.
Yep.
And I wanted to talk a little bit about that before we get more into some of the economics of healthcare in the United States, the political aspects of healthcare in the United States. And by the way, the economics of healthcare is a discipline in universities that's really taught in a rather absurd fashion, because I've got one of the latest textbooks, the most popular textbook in healthcare economics, doesn't even talk about the corruption that we're dealing with in terms of the amount of money that's flowing from the lobby or from the trade associations to legislators. And that's why we need to talk not about economics, not just about political science, but political economy. Because you can't separate political science from economics. And we do that all the time. The two professions don't tend to see themselves as dealing with the same thing, but they are. So we need to begin to unravel this system for people so that they are willing to tell the truth in terms of what these corporations are doing and how the money flows through these corporations, and also how the money flows through politics to keep this system going.
Sure. So that money flow, it's essentially below the table partnership in just about every respect, isn't it? When you really look at it closely.
It's basically legal bribery, corruption. We don't really call it that. After Watergate, we developed an ethos of keeping money out of politics, and it's never been out of politics, but we were in a much better place after Watergate due to the Watergate scandals. But over time, it is as bad as it's ever been in terms of the amount.
Sure. And another topic we could dip into that wouldn't be inappropriate, but maybe not ideal at this time, would be the point at which ethics and morals cease to be the foundation for the basis for establishing laws, legality, and in this area, in any area for that matter. And that separation happened a long time ago, and examples that you're talking about here make that really evident.
If you were to go to Congress, if you were invited to speak at a Senate hearing, and you were to say, look, the problem is we have a corrupt system in the United States, and all of you sitting there are getting money from the very people who are causing these problems. And I'm sitting here speaking to you. Are you willing to quit taking that money? I mean, if you were to talk that way, you would be violating the rules of discourse. Okay. And so
Yes.
what you're expected to do is to go to Congress and talk about tweaking the system somewhat. That's okay. That's acceptable. In fact, it's actually advantageous for the industry because now you are a much needed foil for them. They are much better off having someone coming to Congress who's really not going to change a whole lot, but will play rope-a-dope with you over this or that particular thing that needs to be improved in the system. And maybe over time, you'll get that minor improvement and they can live with that. It's
Sure.
called reform. It's called reform.
Reform, yes, yes. Anytime you hear the word reform, beware.
Right. And, you know, the people who advocate and the activists are well-meaning. They are very good people. They want to see things better, but they are staying locked into this set of parameters and into the guidelines on what we can talk about. I'll give you an example of how that happens. There was a commission during COVID set up by the Center for Medicare and Medicaid, which is CMS, as we call it, part of HHS. It's the agency that's over all of the medicine, Medicare, Medicaid, nursing homes, and so forth. So they had a commission to study what's going on in COVID. This was when COVID was in full bloom. It was like April, May. They were putting this commission together. Somewhere around July, they began to meet. And then in September, they released a report, which was pretty much a whitewash. It just said, well, we need to do more for industry. We need to get more PPE. We need to help them out more with infection control. There was nothing in there that said that industry really had failed to prevent a scourge in institutions for which they are responsible. There was nothing in there that held these corporations accountable. And when you looked at who was serving on that commission, it was professionals, it was physicians, it was major advocates, lawyers who advocate. It was also people that the industry put on there. So it was a good old kumbaya kind of thing. We'll all meet, we'll all get along. And when we come out of this, we'll have a plan and it won't really do much at all.
Right. So what was missing was a strong advocacy for the patient, the person who is residing in these facilities. Yeah.
Right. It didn't hold anybody accountable. I would think a commission to study a disease would say,
this is a homeostasis that's been spent a long time getting well anchored. And it's going to be very difficult to dislodge and alter, isn't it?
That's a good point, because I've studied the history of this industry. It started, as I said, in 1950. That's what I put the starting point at. It could be earlier or later, depending on how you want to figure out the roots. It's been kind of a very crude, greedy, a lot of scandals. When we entered the 2000s, though, bigger entities with more access to capital began to enter this business. So now we have much larger organizations. It's beginning to stabilize. And as we know, with these complex systems, we begin to see more of what was there in the beginning, the spin down. But those things now have been stabilized. They run very smoothly. So we have the real estate investment trust. We have the big holding companies. We're not seeing the same kind of corporation and characters that were around, although we still have some pretty major scandals. But what I'm seeing is bigger capital.
Sure.
More of a facade of professionalism that hasn't been there in the past. But I think underlying problems haven't changed a whole lot. We've seen an immense amount of financial innovation, but no real innovation in the model of care. They're still the same
Yes.
nursing home that we had in
Yes,
1950.
yes. And Dave, I think that's an excellent point at which we should put a pin in our conversation here and encourage our listeners and viewers to stay tuned because this is building toward a very solid explanation for where we are, where we're going, and what needs to be done about it. So thanks again for taking the time to provide this valuable information to our audience. And I'm looking forward to our very next session.
Thanks, Kent. We'll see you next time.
You bet.